Hey guys, welcome back to my channel. Today's topic of discussion is AOZD number 2024 Bulletin. So first topic is obstructive sleep apnea in pregnancy. Okay, so what is obstructive sleep apnea? It is a chronic state of hypoxia. In this condition, it can be both for the mother and the fetus, leading to various complications like hypertension, preeclampsia, diabetes, FGR, preterm birth. Okay. What is the definition of obstructive sleep apnea? It is episode of complete apnea or partial collapse, partial hypopnea or apnea can be seen. It results in decreased oxygen saturation, arousal from the sleep, disturbances, and results in fragmented and non-restorative sleep. So they get up from the sleep, there is total disturbance, fragmented sleep, and they can't sleep again. Okay, and these patients also have snoring. They have spells of apnea and during sleep. You can see elderly people sometimes they'll snore and suddenly they'll wake up. It's a kind of obstructive sleep apnea. Okay, and they'll sleep more in the daytime. Okay, there is one apnea hypopnea index. You don't remember whole thing. Just remember what is normal. Normal means less than 5. It should be less than 5. Okay, so there are two types of obstructive sleep apneas in pregnancy. One is gestational, second is chronic. For example, that lady is having a sleep apnea, obstructive sleep apnea, and she became pregnant now. Okay, so we'll discuss now. So in sleep apnea, what happens is the airway, whatever the airway is there, na, it becomes narrowed, and because of bone deformity, soft tissue accumulation, obesity, tonsillar hypertrophy, edema, and narrowing of the airway in the recumbent position occurs. Why in pregnancy it is worsening? Because in pregnancy there is increase in progesterone estrogen levels. Okay, so the upper airway edema occurs and narrowing of that and diameter decreasing occurs. So there is they may affect the effect. This may affect the respiratory drive and muscle tone. Okay, and there is high resistance to airflow during the respiration, causing mechanical obstruction with the flow of air. And all obviously you can see that in pregnancy there is fat deposition on the soft tissues of the neck. It also results in decreased airway entry, fluid retention, weight gain. And because of pregnant uterus, there's mechanical pressure on the diaphragm. Systemic inflammation occurs, and the Malampati score will be increased in these patients. Okay, functional residual capacity is decreased. These and on top of it, if the woman who is pregnant having multiple pregnancy, diabetes, hypertension, advanced maternal age, obesity, then obstructive sleep apnea occurs more. What is the prevalence of obstructive sleep apnea? 3 to 27%. Okay. Symptoms I already told. You have snoring, you will get up in the sleep. Okay. This snoring and apnea is witnessed by the bed partner. Okay. Then nocturnal restlessness is seen. Okay. Then you'll sleep in the daytime. Okay. Increased daytime sleepiness. And because of that, you'll feel fatigue. Your lack of concentration, cognitive deficit is seen. You can see this change in the mood. Morning headaches can be seen. Okay. These are symptoms. You can easily write. Okay. Nocturia is also seen. Nighttime urination is also seen. How to screen and diagnosis? Generally, in pregnancy, obstructive sleep apnea is underdiagnosed because already pregnancy is a condition where people snore. Okay, people get up in the night. People have nocturia. So there is universal screening for all pregnancies is not recommended. Okay, but high risk women are there, na, like obesity or move 35, 36 plus, hypertensives. These should be at least screened. Okay. There are some questionnaires, stop questionnaire, stop bang questionnaire, and all. You can remember stop snoring, tiredness during the daytime, observed apnea, and high blood pressure. If you snore at night time, then see, snoring is there. At daytime, you're having tiredness or not, you need to sleep. And observed apnea and high blood pressure should be seen. Sleep studies can be conducted at EMGs and EEGs. I'm not going into details. Hypopnea and apnea is something like in hypopnea, there is a 30% reduction of the airflow for 10 seconds, more than 10 seconds. Whereas apnea is there is drop in the flow. There is drop in the flow for more than 10 seconds. Okay, that is apnea. I already told AHF more less than 5 is normal. Maternal complications, obviously same thing. Hypertension, you have cardiovascular disease, risk of stroke, diabetes, then renal dysfunction occurs, memory loss and fatigue can occur. Okay. So poor motor and sensory reflexes can be seen, and if the woman is driving, she can, if these conditions can be predisposed to accidents. Okay, and what happens if the mother having OSA? Then what happens when the fetus and neonate? Neonate can have developmental delays, neurobehavioral disorders if the mother is OSA and untreated. Okay, management in antepartum only. See, patient should prioritize the sleep. If the pregnant woman is working like we doctors work. We have so many night shifts. So prioritize your duties like at least you should have 7 to 8 hours of sleep at night. Okay, and supine position should be avoided. Better go for left recumbent position. Then specific treatments is there like CPAP is better. They'll say that it helpful for maintaining the positive and expiratory pressure at the level of alveoli. Alveoli level it maintains that pressure and continuous flow of air during inspiration expiration is maintained. And some says a CPAP therapy is okay, some says no. But there is a review by this team, Nugent team say that CPAP can reduce BP, can reduce the risk of preeclampsia, prematurity, and low birth weight. Okay. Some people, if they doesn't want unable to use CPAP, then they can use some custom-made mandibular advancement devices so that the lower jaw is forwarded and airway obstruction is relieved. That's about intrapartum, sorry, antepartum. Now coming to intrapartum, CPAP can be used in labor. General anesthesia can have morbidity, so better give them regional epidural only. If there is emergency, they can start with that, right? Follow-up is very important. Okay. So final conclusion is OSA in pregnancy it can lead to the partial or complete upper airway collapse, and it leads to complication. See, it is seen in these conditions in diabetes, hypertension, and it can also lead to diabetes and hypertension. Okay, this is about obstructive sleep apnea. So next topic of this bulletin is coagulative dysfunction peripartum period. See, we all know we have two types of coagulation clotting systems, intrinsic pathway and extrinsic pathway. So what generally happens is first, if for example, if your hand is there, okay, your hand got injured. So what happens? How that blood is being stopped is first there is micro level. There are four phases happening. First things, first thing is there is endothelial injury. The endothelium of the blood vessel which is lining it gets injured. So once the injured, the platelets come and clot it. So there is formation of platelet. This clotting process will increase and coagulation cascade increases that. Okay. So see, clotting process started and continues. Sometime it need to terminate now. So termination of this clotting is by antithrombotic control. Once the clot is formed, blood is controlled. Then the clot should be lysed by fibrinolysis. This is the four-step process how our hemostatic system occurs works in our body. So I told extrinsic pathway. It is tested in vitro by PT, prothrombin time. Intrinsic pathway is by APTT. Okay, so that's why we'll test. See, APTT PT indicates this intrinsic extrinsic system. Okay. So coagulation disorders of two types, acquired and inherited. Inherited we know von Willebrand disease, hemophilia and B. Acquired is DIC and acquired factor 8 inhibitors. And if patient is on acquiredly, it is she is on taking any tablets, anticoagulant therapy, then also she is having coagulation disorder. Now first we'll learn about DIC. DIC is what is DIC? Disseminated intravascular coagulation. That means there is clotting. This is clotting occurring but it loses the loss of localization. What I said in the previous example, if you got injury on the hand, so clot should happen in the hand. But DAC, what happens? Na? It happens in everywhere. It happens in the leg. It happens in liver. It happens in heart. Wherever it like to be, it will form clot. So there is loss of localization. Okay, intravascular activation of coagulation with loss of localization because of different cause DAC occurs, not like every patient have DAC. DAC occurs in different causes. Okay. Mm, so because of DAC there is organ dysfunction, right? And it the DAC is also as concept to coagulate because it is forming clot everywhere, na. So everything coagulating system factors is it is consuming, so it is known as concept of coagulopathy. Okay. So DAC is present in two ways. Okay. So first is latent and compensated activation of coagulation, then overt DIC. First is latent, it is in low phase, it progresses slowly, but overt is something like before only it has overt bleeding and thrombosis. Okay. So what are the different conditions which can lead to DIC? Which condition trigger that tissue clot everywhere? One in obstetric causes, remember, see, obstetrics is like mother, fetus, then placenta. Okay. Whenever you write any question, remember these 3 points. Okay. You just imagine in your brain, okay, this condition, placenta may this condition can cause it or not. Just use your common sense and write the conditions. So first see placenta, placental abruption, right? Okay. P postpartum hemorrhage, right? Hmm. Coming to fetus, IUD. Okay, even fetus are on amniotic fluid embolism can cause it. In coming to mother, there is preeclampsia, there is acute fatty liver of pregnancy, there is petrol sepsis. These are conditions where DIC can occur. Okay, so think like that and you can write the question. Non-obstetric causes. Non-obstetric causes means nothing related with pregnancy. Okay, sepsis, trauma, pancreatitis, leukemias. Okay, hemangiomas, liver disease, liver. See, why liver? Can anyone say why liver? Here also acute fatty liver, here also liver disease, liver hemangiomas. Why? Because liver produces the clotting factors. If liver is affected, DIC comes into the scene. Okay. Toxic insults like snake bites, ABO incompatibilities, transplant rejections. Most of the private hospitals nowadays having these transplant centers, na? So that female lady who had got liver transplant or kidney transplant, now she became pregnant. So she is having a non-obstetric indication for DSC, right? You should remember that one. Next condition is von Willebrand disease. Von Willebrand disease. So von Willebrand is a multi-protein. This factor is a multimeric protein. So basically, if see, this is a vessel. I told na, vessel injured, platelets come there. So platelets coming there and getting like a clump now. For that, the von Willebrand factor is useful. Okay, that three types: type 1, type 2, type 3. Type 1 is qualitative, type 2 is qualitative, type 3 is due to severe reduction. Okay, Mm, and let's see, both type 1 and type 2 are autosomal dominant, whereas type 3 is autosomal recessive. Okay. Uh, so type 1 is chill type of von Willebrand disease. For type 2 and type 3, if newborn also is having the increased risk of bleeding. Okay, coming to hemophilias are X-linked fashion, we already know that. And I told anticoagulant voluntary if some drugs that they are taking, then also you have a risk of DIC. Like if a patient having mechanical heart valves, they need to take anticoagulant therapy. So they have a risk of DIC, right? Then these the low molecular heparin people should have undergone this anti-10A levels. Anti-10A levels. Okay, it should be 0. Like 1. Remember 1. 1. Anti-10A level should be 1. Okay. Then yeah, if they're on warfarin, then target INR should be 2 to 3. We all remember na, INR, we'll see in the reports as 1.1. Remember? But if she's on warfarin, it should be 2 to 3. Okay. Then, if the patient is on unfractioned heparin, APTT levels, see, this is INR, and APTT levels, if she's on unfractioned heparin, should be 2 to 2.5. See, only this paragraph has so many important information. Understood? Okay. If she's taking low molecular heparin, that is enoxaparin, then anti-tenexal level should be 1 in case of mechanical aortic valve. Remember that mechanical valve 1. Even mitral valve also should be 1. Okay. If she is on warfarin, then INR, which is 1.1, should be 2 to 3. 2. If she's on unfractioned heparin, then APTT should be 2. 2 times the normal control. Okay. So many questions from only this paragraph. Okay. Coming to post-vaginal delivery, anticoagulants can be started after 6 hours. But for cesarean section, they say that normal heparin should be started after 12 hours, and that if it is prophylactic dose, and if it is therapeutic dose, because dose will be more, so this dose should be started after 24 hours. Nothing more here. So, what are the investigations if you're suspecting that this patient can have coagulative disorders. Then platelet count should be done. BTCT is done. PT-APDT-INR is done. Fibrin degradation drug D-dimers are done. Okay. Fibrinogen levels is done. Okay. Sequential measurement of fibrinogen is more useful. Blood film is done. Blood film, you can see that peripheral blood smear, I mean. Okay. Uh, this is important topic. I am expecting this question this time. Okay. TEG. In our hospital, TEG is done for only liver transplant department. I don't know why. Because people say that TEG is less important in pregnancy because there are more many factors being affected. So TEG is also done nowadays as an investigation for correlation disorder. What is TEG? Thromboelastometry. What is TEG? Thromboelastometry. It's a part of viscoelastic testing. Viscoelastic testing. What they'll do is they'll take a blood in a cup. Okay, there will be pin inside that cup and it rotates. Okay, if the cup is rotating and pin is hold na. If the cup is rotating but pin is stand, this is rotating, this is rotating here. But pin is stagnant. If the pin is stagnant, na, then it is known as teg, right? Hmm. If the pin rotates, then it's rotum. Okay, that is the only difference. And if you'll get a good marks if you draw this diagram. So diagram has three parts, this, and you can draw a symbol. The you playing cards, you have an A symbol, na? That A symbol you'll draw this. So this first part is reaction time, reacting. Then then you have clot kinetics, clot is forming, then clot get lysed. Okay, this is clot strength, and this is the maximum amplitude. This part is fibrolysis and this is coagulation. Okay, don't go into details. I don't think you'll remember much. Okay. Mm, yeah. So obviously, reaction when a blood vessel, see, again I'm taking the same example. When there is a blood vessel injured, all the clotting factors comes. So it is they are reacting and coming here, platelets, clotting factors, many clotting factors come. So reaction time is for clotting factors. Then clot is formed because of fibrinogen. Okay, there is an angle. Okay, remember. So maximum amplitude, maximum because of platelets, which I already told from the starting onwards. I'm telling platelets, the regular platelet. Okay, so maximum amplitude is by platelets. Then lysis is by fibrinolysis, right? So what is the management in bleeding disorders? What do you do? So if there is a bleeding disorder patient, okay, if a pregnant patient with DIC came to you, she's having disorders like abruption, whatever you learned now. So what you'll do? She's having abruption and she's in DIC. All the investigations are deranged. So first thing you take her to by IV cannulas. Then hemodynamic stability should be assessed. Feed status FHR should be heard. Ultrasound should be done. Okay, medical management should be done, initiate, and these people should be informed and they should be called anesthesia, neonatology, and blood bank. First, patient is stable or not. Yes, fetus is viable and try for normal delivery. If fetus is not viable, already fetus is dead, then don't go for cesarean. Don't go for cesarean. First, stabilize the patient, induce and augment the labor. Don't go for cesarean. If the patient is hemodynamically unstable, first, stabilize the patient. Keep oxygen, fluid resuscitation, volume replacement by blood. Massive transfusion protocol should be done. We should correct the acidosis, then delivery by cesarean section. Okay, understood? Then deliver. First, stabilize the patient. Even in this condition, also it will come here only. If augmentation fails and all, first stabilize the patient, then you do that. Okay. Fluid resuscitation is yeah, I already told. Electrolytes will give two times of the fluid loss. And that 2 liters I told, na, in 2 liters, 1 liter you will give in 20 minutes and second liter will give in 40 minutes. What is massive transfusion protocol? What is transfusion protocol? Massive hemorrhage, you will have 1:1:1 ratio of this transfusion. See, in DAC, PT APDT is deranged and more than 1.5 times of normal. Okay, then you'll give fresh frozen plasma. Okay, understood? Hmm. So based on reports also you should know what to give. Understood? Platelets low, platelets give platelets. If PT-APD-INR is low, then what you'll give? Fresh frozen plasma. If fibrinogen is more, fiber, okay, it's more than cryo you'll give. Okay, more fibro cryo. Okay, Hmm. Newer products are there. Newer products have been come for coagulopathy. See, that is lyophilized human fibrinogen concentrate. So lyophilized human fibrinogen concentrate, where fibrinogen level is approximately 40. Prothrombin complex concentrate being given. Okay, it is derived from vitamin K dependent clotting factors, and we already know this thing. Recombinant factor 7 is it is there since ages. Okay, um, then. Um, Anticoagulants are given in DIC, okay, because DIC is the coagulant condition, so we'll go anticoagulants. So unfractionated heparin can be given. Antifibrinolytic therapy can also be given. See, for giving tranexamic, however, patient with DIC characterized by primary hyperfibrinolytic state who present with severe bleeding could be treated with lysine analogs like tranexamic acid 1 gram every 8 hourly. How do you know whether she is having a fibrinolytic state or not? Fibrinolytic higher, hyperfibrinolytic state or not by means of rotum. I told her that AS graph by means of that. If that in that AS graph, if that fibrinolysis a part is more, then it means there is hyperfibrinolytic state. You can give Tremexa in that conditions. Okay. Mm, I'm not going to details of peripartum management. Let's see the conclusion. So, coagulation dysfunction is one of the major causes of maternal morbidity and mortality. Many obstetric and non-obstetric conditions lead to disruption of coagulative homeostasis in peripartum period. Timely anticipation and prompt diagnosis of this condition by point of care hematological test is important. Early diagnosis and management help to avoid the catastrophic complications. Then, key points is peripartum is a thrombogenic state. However, certain obstetric and non-obstetric condition leads to catastrophic coagulation dysfunction. DIC is also known as constructive coagulopathy. I am telling since start. Then, coagulation dysfunction is a peripartum period. In peripartum period, what's prompt diagnosis, urgent hematological evaluation. Then, rotum is a novel point of care in diagnosis. Okay. So, in key point also, they gave this point. I'm expecting this question. Okay. Next is SLE. They covered SLE in two parts here. Okay. I'll tell you next part. Okay. Thank you.